Hello and welcome, everybody. This is the first PSPS Spine Conference. Tonight, we're going to have a multidisciplinary case-based discussion of lumbar spondylolisthesis. I'm Michael Dorsey, a neurosurgeon at UCLA out in sunny California. I'm joined by an all-star cast of experts, and we'll get the show going.
Okay, so I'm Dr. Rafael Garcia Oliveira. I'm an orthopedic surgeon. I'm a current fellow with UC Irvine.
All right, we'll let our panelists introduce themselves as well in the order that we see here.
Hey, I'm Greg Moore. I'm an interventional pain doc here in Eugene, Oregon with Pacific Sports and Spine.
Michael O. I'm a neurosurgeon, director of spine services at UC Irvine.
Hi everyone, I'm Namath Hussain. I'm a director of neurosurgery, director of spine at Loma Linda University Health.
And my name is Luke McQuaison. I'm a neurosurgeon at Disc Sports and Spine in Los Angeles.
All right, great. Well, with those introductions, I'm going to let Dr. Garcia de Oliveira kick off the presentation.
Okay, thanks. So we're going to go over the basics of spondylolisthesis in order to start up our engines this night. Spondylolisthesis is a condition that has been noted and characterized many years ago. Its name comes from the Greek spondylos, that means vertebrae, and olisthesis, that means failing or slippage. The first time that someone noticed a difference or a slippage between two vertebrae was in 1782, long time ago. Urbino obstetrician, he notes that one of his patients, she had like a difference, a slippage between the sacral vertebra and the first lumbar vertebra. In 1854, Killian, he coined the term, the spondylolisthesis. In 1950, Ian McNabb was the first one to describe the degenerative variant of spondylolisthesis. So we have many different types of spondylolisthesis. Basically, what defines spondylolisthesis is to have the integrity of the pars or not. So if there is something that causes a lesion in the pars will be taking an important role in the spondylolisthesis, or in the degenerative type, the pars remains stable and all the other elements of the spine that are responsible for stability, there is a cascade that leads to the listhesis. So we're gonna focus today in this degenerative type. That means the pars remains without any lesion, and we have a cascade of insufficiency of many of the elements that are responsible for keeping the spine stable. So the definition of spondylolisthesis is a translation of one vertebra over the adjacent. It can happen basically in any level in the lumbar spine, and we're going to discuss a little bit about the levels later on. And it is associated with degenerative change in the anterior and posterior elements of the spine, but you have no defect or disruption in the vertebral ring. There is the pars remains stable. The definition is that you need to have a slippage greater than 3 millimeters or more than 5% to define a spondylolisthesis. So a very famous epidemiological study done in Copenhagen notes that there are some specifics of the degenerative spondylolisthesis. Typically, it happens over 50 years old. It's more prevalent in women than men. And the most common level affected is the L4, L5 level. This is important in differentiating degenerative spondylolisthesis from the ischemic spondylolisthesis that is more frequent in L5S1. But as we can see from this Copenhagen study, while L4, L5 level is the level with odds ratio of 4.0, so it's the most common level, all the L3 and L4, L5 and S1, it can also be affected. But the most important point is that the posterior ring remains stable in order to define degenerative spondylolisthesis. They found in that study some significant factors. For men, age is an important factor. For women, age, BMI basically, and also lumbar lordosis. And something very interesting, there is no association smoking, heavy lifting, seat occupation, and age of menopause or pregnancy. When we think about spondylolisthesis, the degenerative type, as we mentioned before, it happens because of a degenerative cascade that involves disc degeneration. This disc degeneration overloads the facet posteriorly, and then the facet start to have some degeneration as well and some micro instability. This micro instability leads to further degeneration. Eventually, at one point, you have macro instability and anteriolisthesis. This leads to many changes in the spine. And those changes, they can lead to spinal canal stenosis. As we can see here on the figure on the top left, you have a small disc herniation, and this disc herniation, on the image on the top left, you can see the spondylolisthesis itself, and it leads to a stenosis of the canal. On the top right, you can see some disc herniation that is part of this cascade that also leads to spinal canal stenosis. On the top left, on the bottom left image, you can see some facet overgrowth. This facet overgrowth also leads to spinal canal stenosis. And on the bottom right image, we can see that the ligamentum flavum gets hypertrophic, and it also leads to spinal canal stenosis. And we are going to discuss a little bit further the clinical finds in this scenario. But next slide. We also can develop in this clinical scenario another problem. There is a stenotic foramen. So the foramen can be stenotic based on all this cascade as well, as you have loss of disc height in the slippage itself. It can reduce the space of the foramen. And as we all know, through the foramen goes the exiting nerve root. And in a stenotic foramen, you can have a nerve root that is compressed, and it also can cause some symptoms. So based on that, the typical clinical presentation of the patient is back pain, flexed posture, and if he or she develops spinal stenosis, it's also very common and most common to have pain. So pain is the most common symptom for our patients. But in a setting of spinal stenosis, the patients also develop some numbness, weakness in the legs, and neurogenic claudication. There's pain, paresthesia, or weakness, mainly when these patients are walking or standing. And this is very important to differentiate from vascular claudication that happens in patients in the same age, at the same point in their life. So we have a small picture here showing the main difference between those two diagnoses, the neurogenic and vascular claudication, as this is a very important differential. In the patients, they can come to us. Most of the people will have some back pain at one point in their lives, and it's important to be paying very close attention to these symptoms in order to differentiate and do not regard a patient with neurogenic claudication as a patient with vascular claudication. And also the patient can develop L4, L5 radiculopathy that can lead to sensory loss, weakness, and also hyporeflexia. So for our patients with suspected or with diagnosis of spondylolisthesis, the most important imaging is the upper right AP and lateral X-ray. And here on the right, we have the most common, the most used classification is the Meyer classification that classifies the spondylolisthesis based on the level of slippage. So it divides the S1 in 4 quarters. Each quarter has 25%. And as the slippage progress from 0 to 25, it's a grade 1. And each level, more 25% of that is level 1, 2, 3, and 4. The class 5 is what I call as spondylolisthesis. There is like a full slippage of the vertebra. And for the degenerative type, usually the patients, they don't have a grade higher than 2. We also may get MRI from our patients, and the basic indication for MRI is personal leg pain that failed the first non-operative modalities. And next slide, please. In the MRI, the main findings, as we can see on the right side, is facet effusion, synovial cyst. Those 2 first points, they happen due to some instability, and also interspinal fluid, facet hypertrophy, and vacuum disc phenomenon as well. Another important exam that we can make in some patients is the flex tension X-ray. And a very interesting study evaluated how much instability is normal to be seen in normal individuals. So basically, 90% of the healthy and asymptomatic patients, they have 1 to 3 millimeters of translation between some vertebra, L4, L5, L5S1, and only 5% had a dynamic translation greater than 3 millimeters. So what defines dynamic change in the flex tension X-ray is slippage more than 4 millimeters. And this is very important in order to really understand what is a stable or unstable spine. So that's what I had for today. I understand that we have many interesting cases in the next minutes that we will be able to further discuss spondylolisthesis. Thank you.
Well, thank you for that. We're going to now switch gears and go into some case studies that will basically illustrate most of what was discussed right there in the didactic to really bring this back to the real world. These are patients that I've pulled over the last year or so.
Rafa, that was a great presentation. I just wanted to mention one thing about the back pain is that the treatment decision for spondylolisthesis usually isn't based on the back pain component, and there is still significant controversy whether lumbar stenosis causes back pain, and if that's in itself an indication for spine surgery for lumbar stenosis with purely back pain. It's really the neurogenic claudication, the lower extremity symptoms that we as spine surgeons really get involved in. I was just filling time for you, Mike.
All right. Yeah, thank you. All right. Case 1. So we're going to start out with a 43-year-old gentleman. He has been healthy his life. He, works a desk job. Pretty active guy, athlete, mountain biker. But for the past 3 years, he's had clinically significant back pain. He's had a little bit here and there over the years, nothing that required any treatment. When it first started, within about a month into it, he went and saw a spine surgeon who got x-rays and said he had spondylolisthesis and scheduled him for surgery that month. So we decided to get a second opinion. Gets referred to pain management and has an epidural, which was remarkable. He said, for a whole year, he didn't think about his back, got back to all activities, great. Pain came back, said, okay, let's do it again. Got another injection, 6 months relief this time. Again, very happy. But the pain came back just as bad, a little worse. Gets a third epidural, this time 0 benefit, didn't do a thing. So he says, you know what, I need to go and see another pain doctor because the pain now at this point is limiting his activities. He can't play with he has 1 kid, he's hoping to have more. He just can't do the things he wants to do. So he goes and sees you, Dr. Moore, and presents with this MRI.
Mike, I always ask this question.
The next slide.
Is it back pain or leg pain is his primary complaint?
So initially it was back more than legs, and now it is Always back. The back's always there. The legs kick in when he's up and moving around for more than like 5 or 10 minutes. And then the legs get to the point where they're worse than the back. And it's kind of a, just a lateral down the legs through the hips to the top of the feet pain. So now he is, here we're seeing serial MRIs. This is 2018. That was his original presenting MRI. The next 4 there are all the current ones from 2022. And now he is in your office, Dr. Moore, saying, help me, keep me away from the surgeons if you can.
Dr. O makes a great point, asking about back pain versus leg pain. And that's usually a question that we try to get to too, because if you'll take a look at the images, you've got, I assume we've got flexion extension films, and I'm assuming that these are, relatively stable, not a dynamic component. We're talking about degenerative, so, no pars defect here. Looking at the modic changes along the end plate, suggestive for anterior column, component. But, really with his symptoms, it's a matter of, hey, if my numbness and tingling in my legs is, not really that bothersome, it's something that I can live with, and there's no significant motor component, he's not complaining of weakness, and the back pain is, 80% of it, looking at something like an anterior column intervention, prior to BVN ablation, the intercept procedure, we would take axial pain and really treat them, with facet and ESI, interventions. As pain management has evolved and you started to see interventions like Vertiflex for spinal stenosis, indicated up to grade 1, mild for decompression of ligamentum flavum, also with grade 1, obviously, no dynamic component. The 5-1 area in particular is, a bit more challenging with the spinous process. And so the Aurora Zip 5-1 has actually been an intervention that has come along that really, in a 43-year-old, could, give him some benefit for back and leg pain if we're looking at stabilization. But still, really, I would focus, on lesser interventions as long as we could. But if the legs were an issue, and he's seen one of my spine surgical colleagues and been presented with options, looking at something that may be less invasive, like a zip at 5-1, that obviously not burning.
So let's go. Let me
bridges.
interrupt you here for a second. I'll interrupt you for a second here, Greg. So I'll give you a little more, just so we know a definitive choice here, because it's tough with this. Like you said, he has modic changes. He's got, I don't have the axials, but he got big facets. His back pain is definitely more when he stands up straight. So it's more, if he leans back, his pain's worse. The little bit of flexion doesn't really make him worse. So if you had to choose for him, so he says, okay, well, I'll try one more pain management thing right now. Are you choosing a BVN, or are you choosing the facet blocks pathway for him for his back pain?
I'm going to go with the facets based on the presentation that you described, with more extension-based pain.
So he gets his facets done. Blocks work well. He gets 3 months, and he's private insurance. He gets 3 months of great relief with his 5-1 facet RFA. The legs didn't get any better, but the back was worthwhile. So now you're at this point, and he hasn't seen a surgeon since 3 years ago. Are you now talking, in this patient particularly, you're now talking that you're going to do an MIS procedure, or you're going to refer him to a spine surgeon for their opinion first?
I'm going to send him to see a spine surgeon, prior to an MIS, intervention. It's been 3 years, and 3 months of clinical relief is, it's really not enough to justify another intervention at this point. I just want to make sure his imaging's up to date. So, we'd refresh that.
Yeah, this is his date.
And then we get him teed up.
Yep.
Obviously,
Right, so
he's been through physical therapy.
Mike, can you confirm that there's no abnormal movement on flexion extension?
So there's as much abnormal movement as you want. There's at least 3 millimeters. It depends on how you want to measure it. He does have there is an element of instability.
Okay,
there when
3
he
to
flexes
4.
and
So it
extends.
could
I didn't
be
put that
either
in this
way.
one. I have them for most of them. It can go either way. The radiculopathy is L5 radiculopathy, as was pointed out. You look at these foramen and severe foraminal stenosis hitting the L5 nerve roots bilaterally, neuro intact. So he comes and sees you, Dr. O, after the injections and the facet blocks failed. What are your thoughts here? He wants to be treated. He's 43. He wants to get on with life.
Yeah, the back pain question is really important for me. And I know that there are patients that just refuse to answer that question. I ask them, is it back or leg? And they said, it's both, doc. It's both. And I have to pin them down. I said, if I give you a token and you can use it to fix your back pain or leg pain, what are you going to use that token for? So if they tell me it's back pain, then I'm going to move more to the fusion. If they say it's more leg pain, I'm going to think about just a simple, minimally invasive decompression. And I think it's changed now that we have tubes and we have endoscopic. There are lots of minimally invasive surgical ways to decompress that foramen without causing much more instability or very minimal risk of that. So I go for that. Those are from a surgeon perspective. That's where I go. RFAs in a 44-year-old. I generally try to stay away from RFAs in young people. And the basivertebral nerve ablation. If I try to get to the cause of the pain or the root cause of the pain rather than symptomatic treatment in general, from a surgical perspective.
All right, we're going to keep on these lines. Building on those points, which are very salient points. He said that when he didn't have the back pain when the RFA worked, he didn't have the back pain and he was much happier. Every day he woke up in a much better mood. He still couldn't do all the things he wanted to do because with activities, the legs would kick in. And so he couldn't get back to activities, but at least every day his life was better. And so then, he sees you for this and you go through these and then he goes and sees Dr. Hussein. And he wants specifically to ask him about how easy or how successful it is to decompress specifically the L5 foramen endoscopically.
It is a challenge. He does have a decreased foraminal height and decreased disc space height at that level. Oftentimes, when I look at endoscopic decompression, I'm looking for disc space height. If the disc space is still tall, that means decompressing disc material in that foramen will help. However, if there's still a lot of bony stenosis, especially from end plate changes, and that end plate disc interface contributing to stenosis, it's going to be a difficult job to decompress that foramen. Things that I'd look at based on this imaging, on the middle and on the middle right, it appears that there may be pars defects. So I'd make sure we get a CT scan and then I'd complete that obviously with the flexion extension films. But if there's any pars defect or instability on flexion extension, I'd lead more towards fusion. But I think endoscopic decompression, if they're looking for something more minimally invasive, is totally an option. With the caveat that it's not going to fix any component of back pain, that it's really designed for leg pain relief. But also, I just kind of walked them through the paradigm that one therapy does not necessitate giving up on another. So I typically have them go with the least invasive option first. So if their leg pain is a significant contributor of their symptoms, then I recommend an endoscopic decompression at L5S1. If after 3 months to a year, they feel like, hey, you know what, my leg pain is improved, but not perfect yet, but my back pain is still nagging, then I think more towards a fusion procedure.
Yeah, Namath, I agree with you. With how wide that central canal is at L5S1, this patient almost certainly has a pars defect of some sort.
Yeah, there's a unilateral pars defect and an elongated pars on the other side. All right, so Dr. McQuaison, do you have a definitive surgical solution for this patient that could fix both his foraminal stenosis, relieve his radiculopathy, and stabilize and help his back pain?
Yeah, I mean, listen, if you put the question that way, yes. I mean, I think there is a definitive solution. In my from my perspective, the solution would be some sort of an anterior fusion, however you like to do that, because that allows us to stabilize the segment, which has a pars defect, hopefully eliminating the patient's axial low back pain, and at the same time decompressing the foramina and the nerve root, which is clearly causing his radiculopathy. So that would be my answer if you put the question that way. If he was improved with injections or with these RFAs, and he was still mainly just complaining about radicular symptoms, I would say probably the first thing I would offer to him would just be a minimally invasive, like a tubular decompression to decompress this left nerve. I believe it's the left. I don't know.
It's bilateral.
It's bilateral. Okay. Well, if it's
Bilateral.
bilateral, then I probably wouldn't offer him the decompression. Then I probably would offer him an anterior approach.
And you got exactly what you wanted out. So 2 years post-op. So you had an anterior posterior approach, realigned him, stabilized him, decompressed his foramen, back, legs, home run on that one. We'll have some ones that aren't as rosy, I promise.
So, sorry, one real quick comment, because Dr. Moore mentioned the posterior spinous fixation fusion, the Aurora zip kind of spinous process. With a disrupted pars, that one definitely would probably not be effective in that case with a pars defect.
Yeah, I wonder also the effect that would have on the the horizontal and vertical stenosis of the foramen as well. In my mind at least, opening up the foramen circumferentially and realigning opens those foramen better than anything else in that particular case. All right.
Yeah, man, I am not
moving
aware.
on. Case 2.
No, sorry.
Very different patient now, physically. So now we have a 70-year-old, highly active Californian 70-year-old, with mostly radicular symptoms, butts, thighs, down her shins, front of her shins, not really any back pain. And she does not have any instability at all. So what you see is what you get here. She has zero instability on flexion extension films. She's osteoporotic with a T-score of -3.2. She's already done all the injections. They all provide a little bit of relief here and there for her legs, but it's really, she can't do the things she wants to do. She had to drop out of Zumba class because her legs just don't let her do it. So we'll start again, Dr. Moore, because now we have a 70-year-old. Looking at this imaging, and you mentioned,
Mike,
three of the
quick.
things that
Bilateral
are in your
or I missed-
repertoire as a.
Sorry, Mike, I missed it. Bilateral or
This is bilateral. Bilateral. Any given day, one can be more than the other.
And Mike, is this
And so
area
starting
that-
with Dr. Moore. So Dr. Moore, you've done all the injections.
Sorry, Mike, one more question. Is this the
What was that?
area of the most significant stenosis in the lumbar spine?
Yeah, this is the only significant one when you look at it. And the foramen aren't bad at any level here.
Okay.
So we'll kick it off, Dr. Moore. You mentioned all the the 3 kind of MIS procedures that are out there nowadays. Are you proceeding with that now, surgeon? Both? Where are you with the 70-year-old with osteoporosis?
Yeah, I mean, with the interspinous devices and the osteoporotic, T-score in the spine and -3.2, I think that's not something that I would pursue. She doesn't have a significant amount of ligamentum flavum hypertrophy. It looks like maybe 3 millimeters there. So, it looks like the majority of the stenosis is coming in the foramen, and maybe symptomatically she has some component that's really all leg. So I don't know that I've really got an intervention for her. If we've tried other injections and she doesn't really have any low back pain, it's not an ideal candidate for any of the MIS treatments.
All right, Dr. O, you operated on one of her neighbors who did a clean out job. She says, can you do the same for me?
Oh, absolutely. So this was again, so you don't have the X-rays there, but you said there's no instability. There's a little bit of a slip there, so this would be
None.
just it's bilateral. So instead of doing 2 tubes or torturing myself with an endoscope for 3 hours, I would just do a small midline, just a intersegmental skip, kind of small laminotomy bilaterally with curved kerosins, and it's really lateral recess stenosis. You could get in and out in 40 minutes at the most, and that would be it. And she's looks like a pretty thin patient. There's not much fat there, so there's no point. A lot of the MIS things doesn't make sense here. The key in this 7-year-old is to get her off the table pretty quickly and decompress both sides. So this one is easy outpatient, 45 minutes at most, bilateral, laminotomy decompression, curved kerosins.
Anyone doing tubular, unilateral tubular or endoscopic in the group?
I mean, for most of my bilateral lateral recess stenosis cases, I'll do a unilateral tube, but I'll do a unilateral laminotomy and with a bilateral decompression. So I'll either turn the table or tilt the tube another 20 or 30 degrees and reach over the thecal sac and get to the contralateral lamina. I feel like, it's just a shorter time and it's less tissue dissection. And I totally agree with Mike that metrics, MIS decompression is the way to go for her. I think, the place that endoscopic decompressions really shine is in a younger person where you can take your time, or in an obese person where there's going to be a lot of tissue dissection. But with a thin person, 70-year-old, you want to get them off the table. Metrics decompression is going to be the fastest way to do that with excellent decompression.
Perfect. And next slide. This was that's what I do nowadays too, but this was actually David Westra, a fellow Loma Linda person. This was his case, and he presented this a few years ago, but 1.8 centimeter incision, tubular decompression, you get all that ligament flavum down. And she was doing great. No tricks there. All right. So now we're keeping with our 70-year-olds. Another active 70-year-old. 1 year of right L5 radiculopathy. It is as textbook L5 as it gets. Started in her hip and then started to go all the way down her leg. Lateral leg is the worst, from the knee to the ankle onto top of her foot. She has weakness in her EHL. She really has no significant back pain. She can't lay flat in bed though. So she's been in the recliner for a year. She can't stand and walk. If she sits, it goes away completely. In the distant history, she had right-sided decompression at L3-4 and a left decompression at L5-S1. She did great from those surgeries, but now she's 20 years later in life. So here's her imaging, which, on her laying flat MRI, you say, well, why are we showing her in a spondylolisthesis talk? But you see it, at L4-5, she's got pretty significant lateral recess stenosis. Symptoms are on her left side, on her right. She's right side, sorry, right side. Right-sided symptoms for her. And you can see there the really thickened ligament flavum, like Dr. Garcia Oliveira had highlighted in one of his slides. The big facets, the classic stuff. Once again, of course, she had her injections. Every single one worked. But in a year, she had 3 in basically 5 months, and now she's out of injections. So we will start once again with Dr. Moore. What do you got for her?
This may be a good candidate.
She's not osteoporotic.
Yeah, this may be a good candidate for something like mild there, with the significant ligamentum flavum hypertrophy. She's had a series of epidural injections already. I think that would probably be a reasonable option for her.
I have a mild question for you for that thought. So mild takes down the central stenosis, the ligamentum flavum of the central region. So in a patient like this, where it's unilateral L5 radiculopathy from the lateral recess stenosis, what's the outcomes with those patients particularly?
So, the concept is less is more, with mild. And so, the amount of ligamentum flavum, debulking, I think is minimal. We're not going to get in there like the previous, case that you presented. But, the idea that, she really has quite a bit of pain with walking, we're looking at, hey, how can we improve her functional benefit? I don't know if she has other comorbidities, other significant issues that, may create some issues with, prolonged anesthesia, or, something along those lines. But, mild is something that's really super minimally invasive, and, they tend to do fairly well in the short term in terms of recovery, and the anesthesia burden is very low.
Okay, very good. And so we're going to show the next slide in a second, but two things I wanted to point out on this one. This is a patient with zero back pain. Her L5 S1 end plates are as modic as they come, and I don't even see a multifidus muscle on her. So just very, very interesting how when we take image findings in isolation, they don't really fit with patients sometimes. So we'll go to the next slide. And now here we go again. So here's her flexion extension x-rays, which I withheld on purpose there. So I highlighted it because the x-ray doesn't show up too well, but there's clear instability here at L4, L5. She goes from about 1 or 2 centimeters to 5 or 6, at least 6 on flexion extension. I assume for mild, this would still be a mild candidate in my mind. But let's say she doesn't get, she skips over Dr. Moore and is now with you, Dr. Hussein, for her right L5 radiculopathy with a mobile spondylolisthesis.
I think the data has shown that for these cases, as much as you want to keep things minimally invasive, and you can still with the minimally invasive fusion approaches, but minimally invasive and decompressions are probably not going to be the durable therapy. So minimally invasive fusion, I think, is going to be the option here. Looking at her MRIs, you can see some signs of obesity, and looking at her axial MRI, you can see that her psoas anatomy is not really ideal for a lateral inner body approach. So I'd think about a fusion procedure to stabilize the joint, align her, and increase foraminal height. And so I'd think about a TLIF procedure. MIS TLIF, I think, is a great option in this situation where it's a minimally invasive approach. The incision is not much longer than a Metrix tubular approach, and you're able to put perk screws to realign the spine. So I think that's a great option. If she has unilateral symptoms, then I do a unilateral TLIF approach, do a complete facetectomy through the tube, and then put the inner body device in there. If she has bilateral symptoms, I do that same approach as I did initially, and then I do a tube on the other side, and then I do either a medial or a complete facetectomy on that side as well before putting in perk screws. But I think this is where MIS TLIF really shines, and you want to look at patient-specific anatomy and your surgical goals. There's a lot of ways to skin a cat and do a fusion, but in terms of my mind, those are the things that I look at: A-lift versus X-lift versus T-lift. Is basically patient body habitus, looking at vascular anatomy on the MRI, and looking at psoas anatomy on the MRI, and then figuring out an option for the patient that is least invasive. And I think this is, different approaches really shine in different patient populations, but this is kind of the ideal candidate for an MIS TLIF, I think.
All right, my thoughts exactly. And she said that her neighbor had a TLIF at the hospital, got infected, turned into a horrible disaster. She would never have a TLIF ever, and she would never go to the hospital ever. So she took that one off the table for me. Dr. McQuaison, you got any? Would you recommend something different? That was my first thought.
Yeah, so you're convinced that there is instability here, or obviously these extra, I mean, at least you said, because you said 5-6
and her
millimeters
joints, big effusions in her joints too.
Yeah. I mean, just because the listhesis itself doesn't worry me for a decompression surgery. As you guys know, there's data to show that doing a tubular unilateral decompression, even with some of the grade 1 spondy, doesn't increase the rate of progression in grade 1 spondy. So I have to be honest, in a person her age, osteoporosis and all the other stuff, obesity, I would still probably try that first. The absolutely worst case scenario, which is still once again, unlikely, but that this thing continues to progress and causes symptoms. So if I remember, her radiculopathy was the only symptom you said. She had no back pain whatsoever, right?
Pure ridic. Yep, correct.
Yeah.
All right,
I
and
do
let's
a-
kick this back full circle to Dr. Moore. Oh, sorry. Go ahead.
No. Just say I would at least offer her the
Luke's
decompression,
recommending lateral
decompression without, with the kind of the attendant risks of just doing the decompression in light of a potentially, mobile spondy. If she understood those risks and said, listen, I don't really want to do that, and I want you to take care of my spondy, and I don't want to take the risk that this progresses and I need another surgery, and she hates the TLIF, I would just perform, once again, my preference here, especially at 4-5, would be an ALIF with a percutaneous fusion.
All right, and then Dr. Moore, she comes back to you. She says, hey, I've seen all these surgeons, they all want to cut me. You got anything for me? Besides the mild?
Yeah.
With the spondy.
Yeah, besides the mild, this is without the osteoporosis, this may be a good candidate for something like the interspinous stabilization, Aurora Zip. Be able to look at that, mobile segment, may be able to get some reduction with that.
So I've obviously been way too influenced by my experience with PSPS, but I did a hybrid of this. So I told her that we're going to decompress her nerve. So we did a hemilaminotomy. But if it looked unstable and if the joint was horrible, which it was, then we'd have the option of doing just like you said, Dr. Moore, and clamping her. With the addition of drilling down her facets, packing them with bone to get a little more arthrodesis than what you get through the little hole in the clamp. So she's better for the most part, but she's still not perfect. She can't lay flat in bed still. She gets leg pain when she lays flat in bed, just between her knee and her shin. So she had to get another injection. So we'll see. She's a continuing project. We'll skip through her post-op scan, which is the next slide. She has a little bit of a synovial cyst now, which we'll deal with if we need to down the road. Let's go one more slide. We'll keep moving.
So before we leave that case, Dr. Dorsey. So
yeah.
how do you know she would have done better without the clamp? If you had just done
I don't.
So I would have probably done a biportal endoscopic on her and just cleaned up that one lateral recess stenosis. So how do you know that you didn't create some of her pretty good but not great outcome with the clamp? Because
I'm sure that I don't think the clamp. I think I created some of her instability by taking off some of her facet joint, because I had the nerve was pretty far underneath the facet. It's quite a medial facet. So I don't know whether you do that endoscopic, tubular, or open to really decompress that L5 nerve root in the lateral foramen and the lateral recess. You got to take off some facet joint.
Yeah, that's why.
But I don't know if the clamp caused problems.
Right. So that's why.
Yeah, the endoscopic. But still, when you do it endoscopically, you're still pulling down the facet, right?
Yeah, but you're going with biportal, you're going more medial to lateral, whereas with a tube, you do have to take off that medial facet. That's one of the things that I worry about in some of my tubular cases. So with the biportal, you still go medial to the lateral, just less tissue disruption, especially in a person that already has a pre-existing slip with some movement. And then the problem, or not the problem, the potential issue with the spinous process clamp is that you're fixing them and creating potentially some sort of kyphosis, depending on how they're positioned on the table, right?
Dr. O, let me ask you, I agree with you.
That is true.
Process. Let me ask you, how many, because you mentioned the thing about the facet, which I agree with you, the tubular decompressions, but how many of your patients, not other people's patients, but how many of your patients, in your experience, have you brought back and had to fuse after a tubular decompression? My guess is not many, but I'm just curious.
Not many. It's theoretical, but when I get the post-op, sometimes they have persisting pain, things like that.
Yeah.
I get follow-up imaging, CT scans, and it's a good medial half of that facet that's taken down with the tube. So it is, you're right, more of a theoretical concern than, but
yeah.
So yes. I haven't seen much of that in my tubular cases, but it is a theoretical concern. That's why I'd rather go medial to lateral in those kind of cases.
Understood. No, I mean, that makes sense. I mean, if you can, yeah.
Yeah, I think that's going to be a growing option. I mean, we're starting to get our hands on endoscopes. As you know, it's still new for your hands and Dr. Hussein's hands, and I know Dr. McWisen's just starting out with it too. So I think this discussion might be a lot different in a few years. Let's go to case 5. So skip through case 4.
Sorry,
Keep going.
Dr. Dorsey. There are some people that are putting in questions on the question and answer part.
All right. Let's see.
There was some question about the Vertiflex in particular.
Oh,
I'm not sure if
well,
about this case or the
let's
last.
go with case 5 then.
Oh, perfect.
Let's go with case 5 for the thoughts on Vertiflex, because we'll touch on that here actually, and we can have Dr. Moore and our surgeons talk a little more about their experiences. Case 5. So a 73-year-old male, and this is before I knew him, worsening low back pain over 4 years, failed epidurals, could only walk 100 yards before he had typical shopping cart neurogenic claudication. His MRI at that time, he had a really slight spondy at 3-4 with severe stenosis. L4-5, he had complete disc degeneration with really no stenosis. And L5-S1, complete disc loss with minimal stenosis. Very much neurogenic claudication more than back pain, no medical comorbidities. Well, we know what happened here, but anyway, so he got Vertiflex. So he got Vertiflex at L4-5, did 0. Got Vertiflex at L3-4 3 months later, did 0. Now he's back with increased back pain compared to a year ago. Legs are just as bad, but his back is now worse than ever. Overall 6 out of 10. Can't really do a whole lot of just basic stuff. Saw someone who recommended transfemoral endoscopic decompression on one side for one of his legs and then come back for the other one. And he wants another opinion. So we'll go to some films here. So here now are his x-rays. You see the spine spiders sitting there, but let's just rewind a minute. So Dr. Moore, again, 73-year-old with neurogenic claudication, severe stenosis, grade 1 spondy at L3-4, failed epidurals. In your hands, reasonable candidate for a Vertiflex?
For me, I think maybe early on and prior to some of the interspinous stabilization, like clamps, I might have considered Vertiflex, but I've just seen some subsidence, or with this much of a spondylolisthesis and severe stenosis. I mean, it's typically mild to moderate. If we're talking about an 83-year-old with a lot of comorbidities, I might look at something.
73.
Yeah, I know, but I'm just saying, if he was older, had more comorbidities, didn't have other options, maybe. But this is really somebody that I might, either look at something like a clamp, or I definitely get the surgical consultation. The 4-5, I don't know what the MRI looks like. I mean, it looks like he's got some stenosis there on the X-ray, but yeah, I don't know that I would have gone with 4-5 as my first choice.
Right, and then, I sometimes wonder how things get chosen in order by some of my colleagues. Dr. Garcia de Oliveira, what do you think's gone on with his Vertiflex implants here?
We can definitely see that it created some stability in the spine, and it didn't bring more stability for this patient. So definitely we can see that there was some progression, and we also can see that the patient lost a little bit of her normal lumbar lordosis.
Sure. What do you think about his L3 spinous process?
Yeah, we can see a fracture there. The device, or we had some osteolysis there, or the spinal.
That's a fracture. You got it.
Yeah.
This should be his MRI next. So here you get a good sense of what that L3-4 level really looks like. Dr. O, you mentioned endoscopic surgery. This is neurogenic claudication, worsening back pain, spondy. The recommendation is for separate transforaminal endoscopic decompressions. What do you think of that for this pathology?
Well, the spondy reduces when they lay down for the MRI, so it's better on this than the uprights. So I think they're going to need a fusion and unilateral endoscopic. I don't know. See, that doesn't make sense for bilateral. Even if you want to stage it, I think that this person's going to need a fusion, at least at that level. You can maybe need some, if they want to do a foraminotomy endoscopic at the 4-5 level, that's okay. But 3-4 needs a legitimate decompression and fusion.
All right,
That's my
sounds good.
bottom
And 73-year-old with this pathology, and we'll just focus on the L3-4 level for simplicity's sake. Dr. McQuisen, what's your preferred approach for that with this guy's L3-4?
I mean, I agree with Dr. O. I mean, it looks like it reduces really nicely. So it begs the question of how unstable this is. Once again, I would get a CAT scan, see if there's a pars defect. Given his age, if it's a pars defect, it doesn't have a pars defect and grade 1 spondy. Once again, I hate to sound redundant, but I would still first and foremost offer him a unilateral tubular approach to a bilateral decompression. If I thought that, once again, there is a pars defect there and he's mobile, then I'd perform a single level fusion. I think in this case, at 3-4, it can be performed either at an XLIF, or you can, I would directly decompress this. So I think it would be also reasonable to do a TLIF approach, because then you could directly decompress, place the cage to a bilateral screws, if that's what's necessary. But I would start with, once again, just
Have you done a tube with a vertiflex in place?
I have actually just last week. It wasn't really in the way. And there was actually one I did like 2 months ago. I don't think that was a vertiflex. It was an older device. Oh, it was the Lang's interspinous device. That one I had to remove because it was so in the way. I don't have a lot of good things to say about the vertiflex device, because in cases like this and with stenosis this severe, I just think it just leads to problems, as it has in these cases. The reoperation rates for that device are too high for my clinical use. So I think it's possible to decompress the guy. And once again, I think just given his age and medical status, there's very little risk in a unilateral decompression. In my hands, that procedure takes less time and less anesthesia than these two vertiflexes. And I feel like the patient's symptoms would be relieved. And should he develop mechanical low back pain due to some instability, you can always bring him back for some sort of percutaneous fusion.
Yeah, he's kind of got a lot of mechanical back pain, which kind of went into my decision making here. But Dr. Hussein, so let's make the mechanical back pain as important to him as the neurogenic claudication. What's your fusion of choice here?
Yeah, so this kind of workflow or this patient presentation is something that I see commonly. You'll see this in your practice for the young residents and fellows and attendings who are on the call, but you often see a minimally invasive, spine approach like a vertiflex or other approach, a midline approach that has failed in this situation. And so what I'll do is I'll immediately, at the beginning of surgery, make that same small incision midline and remove the vertiflex, which is not a large surgery to do. Just the pieces just come out, and then after that is done, then I'll do my approach for the MIS TLIF. Again, like I said, you're looking at ALIF, OLIF, XLIF, TLIF. Looking at the anatomy, these images will tell you all that you need to know. And so you're looking at a spondy that is a slightly mobile. You're looking at vascular anatomy. You're looking at psoas anatomy. And the image in the upper right shows you vascular anatomy that is not ideal for an ALIF. Also in the upper right, you're looking at psoas anatomy, and we call this a Mickey Mouse psoas. So the head of the Mickey Mouse is the disc, and the ears of the Mickey Mouse are the psoas muscle. So that is not ideal psoas anatomy. You can see the nerve root bundle in the white region, kind of at the 50-yard line of the disc space. And so that's going to be where you want to place your XLIF cage and do your dilation. So that's not the ideal candidate. You want the ears of the Mickey Mouse not to be riding high, but to be riding quite low. And that's a better candidate for a PTP or a prone lateral interbody fusion or a lateral interbody fusion. So I think the ideal case in this situation, because of that fluid in the facet, because of that severe stenosis, because of the mobile spondylolisthesis, all these things are making me think that a standalone decompression is going to eventually fail for this patient. And my preference is this patient has already had multiple interventions. They've had multiple vertiflexes. They've had multiple injections before that. How long are you going to keep on dragging out his care forever, you know, giving him little procedures, little patches here and there? I think they need something definitive, and I think the MIS TLIF is what I would offer.
So
Dr.
next
Hussain,
slide.
Can you explain to people why, you made a very good point with the Mickey Mouse ears, but you explained to, I guess maybe the listeners, why you think the ALIF approach here would be unfavorable?
Yeah. So you're thinking about ALIF and OLIF, and so
Back
ALIF,
one.
yeah. Yeah, so you're looking at the vascular anatomy, the vascular bundle in the front. So an ALIF approach was not ideal in this situation. It can be done, obviously, but for me, I think that's a more morbid procedure and for not a lot of benefit. However, you can see in the image on the upper right, you see that corridor between, I mentioned a bunch of approaches and I forgot to mention OLIF, between the vascular anatomy and the psoas on the left. You see that fatty area, that's clean fatty area of the anterior disc space. So that would make something amenable to an OLIF, but I also look at the junction between that fatty area and the psoas muscle and how easy it would be for me to retract that psoas posteriorly. And I hate to I don't like to, my preference is for foraminal height. I know a lot of people, when you're thinking about placing your inner body, you're thinking about placing it posteriorly, medially, and anteriorly. If you're looking for more lordosis, typically, you can place it more anteriorly. If you're thinking about more foraminal height restoration, you place it more posteriorly. And I think especially because of that psoas on the left side, really getting on top of that psoas anteriorly and pushing it backwards, getting an implant into this space, I feel like it's going to be really, really difficult to retract that psoas so posteriorly to get a good implant in the middle of the disc space or even in the posterior aspect of the disc space to really make the OLIF an approach that I would recommend either. So I think, you know, keep it simple, keep it easy, get the patient on and off the table quickly, avoid the anterior approach with a vascular surgeon, longer operative times, risk of DVT, unless you really, really need it. I think the MIS TLIF is going to be much better for this patient.
So here we see just a better view of what the bony anatomy looks like in that fracture through the spinous process. And the other thing that sometimes creeps up into your question, Dr. McQuarrie, in the older population is the vessels can be quite calcified. His aren't. But certainly that's something I always look at too when I'm deciding on whether I'd go anterior on an older person. So in line with most of your thoughts, wanting to treat his back and leg pain, but wanting to do it in the longest possible way. So MIS robotic minimally invasive TLIF allowed me to work around the vertiflex. I just left them in place because they weren't in my way at all when you come through a Wilty approach. And he did really well. Haven't had to do anything for the rest of his back. All right, well, it's 7:35. Spine surgeons, I can go all night. It's kind of up to our audience and our faculty whether we want to keep going longer. I have plenty of cases. What are your guys' thoughts?
Michael, I'm gonna have to bounce here in a few minutes.
That's what I figured. Yeah, so we will what we'll do is, you know, let's go to some of the last slides, the PSPS slides, Lauren. So we have a lot of cases, and I invite anyone on this call in our audience to really get more involved with PSPS, because this is the kind of stuff we love to sit around and talk. Some great opportunities to do that. Coming up next week, Dr. Hussain, you want to introduce your baby here?
Yeah, encourage everyone to sign up for our Fellows Lab. This is going to be a course designed for residents, senior residents, fellows, and new attendings to go over MIS approaches. We've got an amazing curriculum. We really find a lot of value in coming to our lab. We're going to go over OLIF. We're going to go over prone lateral interbody fusion. We're going to go over lateral position, lateral inner body fusion. We're going to go over so many different approaches, things that you'll be using immediately. All the cases that we talked about today, that's the stuff that we're going to be talking about in this lab. So you'll find a lot of value in coming out. We'll host you at Loma Linda. We're having it at their Mission Inn, our dinner, and your hotel stay is paid for as well. So really try to make time to come out. It's May 18th. You'll be arriving on a Friday, having dinner with us, and then courses on a Saturday. We'll be done by 5 p.m. and you can fly out right after that. But I encourage you guys to come out. It's going to be a great course with a lot of great faculty. We also have we're going to be teaching flare hawk as well and endoscopic. So please come out.
I'll be there.
And then adding to that, if we have young spine surgeons or spine fellows that want to get involved with PSPS, we have a program for leaders in training, which we really encourage younger spine surgeons to look into on our website. It's really a program designed to let you get started with a society where you can get on podiums, start talking, start teaching, and get involved, which sometimes can be quite hard to do in some of the some other societies that have kind of the old guys club. So we really like to encourage the development of our younger society members with PSPS. And then of course, this one's Dr. O's baby. Go ahead.
Yeah, this is going to be right in our backyard here in Orange County. It's at the Fashion Island, the Pendry Hotel. It's a great venue. We've got a star cast of keynote speakers and just a great agenda. I think anybody that's interested in this confluence, this area in MIS, whether it's MIS from the pain perspective or MIS from the spine perspective, it's either going to be conflict or collaboration, and we're on the side of collaboration. So hope that you look into it, come on out and see the future and the beach.
And also, exactly, and keep your ears open, everyone. We're making a concerted effort to do local regional meetings. We just had one up in Ventura County. We'll have them throughout the western half of the country. Dinners where pain management doctors and surgeons can sit down and do just like we did today, have open collegial discussions about cases, about the stuff we love, enjoying a good meal and enjoying good company. I'm going to kick it out. I like to end with final words from each of our faculty members. We'll go in the order that they introduce themselves. Something inspiring. Dr. Garcia.
It's great to be here. It's great to be in this discussion. It's so great surgeons, and thank you so much for having me here and for everyone that joined today.
Dr. Moore.
Dr. Dorsey, thank you so much for having me here on this panel, and to all my colleagues, thank you for a excellent discussion. And I learned a lot. And I think to Dr. O's point, the collaborative aspect of this, when we all work together, we all get better. So thank you.
Dr. Hussein.
Thank you guys for coming out for this webinar. I appreciate your attendance. Again, we're going to try to do more and more of these webinars and provide more value, more content for you as part of PSPS. Some of that value-added content is going to be at the May 18th lab at Loma Linda. Some of it's going to be at the PSPS conference in Newport Beach. Again, if you like the collaborative nature of today's talk, the bouncing of ideas back and forth, I mean, this is what you're going to be doing when you're in practice and when you're continuing with your practice, learning from other people around you. And I think if you want to be part of this collaborative environment, I encourage you to come out. There's a lot of new content, a lot of new speakers that we have, a great agenda. So appreciate your attendance and love to see you there in person.
All right, Dr. McQuarrie.
Yeah. Thanks for everyone and thanks Dr. Dorsey for inviting me. I think these kind of webinars are great. I encourage everyone. I guess we should do it more often. That's how we learn and all get better. And believe it or not, I learned just as much as kind of the younger folks on this webinar. So thank you for organizing this, and I hope we get to do more.
President O.
Rafa, thank you for your slides. Dr. Dorsey, thank you for great moderating. Dr. Hussain, thank you for all of your support for PSPS and the great lab you're putting together. Dr. McKazen, look forward to running into you again, or your company that you've launched. And Dr. Moore, want to thank you for being the brave pain physician surrounded by spine surgeons. Really appreciate you. Thank you, everyone.
All right. Well, with that, we'll call it a wrap. Thank you to the faculty, attendees, and SCORE for putting this together. Hope to see you all at PSPS events soon. Good night.
Bye, everyone.
All right, bye-bye.